we sent this out last week, but we'll come back to this because I just want to get to Emily and then we'll come to the stuff that we have. But as a reminder to y'all, it was Emily, I looked back and when you and Rahul came and it was last August. So welcome back almost a year later.
Yeah, thank you. Oh, no, I was just going to say Emily's going to be here presenting for us. I'm excited to hear this and updates from Texas 2036 as we gear up for session and next year, but it's going to come very quickly.
Yeah, it sure is. Are y'all, am I good to go? Okay, great. Hi, everybody. Thanks for having me back. Emily Brizzolara-Dove with Texas 2036. We're a nonprofit, nonpartisan think tank based here in Austin. I hope everybody is staying safe. I know my grandmother is still without power in spring, so I know that it is tough and I appreciate your attention, especially because I know some of you have heard part of this presentation before. Iris may have it memorized by now. So I'm going to do two things today. I'm first going to do the extremely high level, very fast run through of our Who Are the Uninsured project. This project has been ongoing for my entire time at Texas 2036. I just put a link to the full report in the chat. Let me go ahead and pull that up. Okay, and if I can get it going. Our Who Are the Uninsured project is one of the most comprehensive studies of uninsured people in the country. The genesis for the project kind of started with, the acknowledgement that Texas has the worst uninsured rate in the country. And instead of just kind of starting from there and going blindly, we decided to talk to the uninsured people in Texas and determine what their barriers are, who they are, what their barriers are to receiving insurance. And it has bared tremendous fruit that I hope is interesting to y'all as well. After I do this very fast run through, I want to talk in a little bit less formal way about some of our housing work and how I think that it connects to your social determinants of health work. And just we have a spin on it that I think might be interesting to y'all. But I'd really like to hear your feedback on that as well. So we'll go ahead and dive in. We started this project in early 2022 with a literature review of existing research primarily from ACS. Now, ACS asks one question about why people are uninsured. So there's a heck of a lot of nuance that's lost there. And so we decided to dive in and do a survey of 2,100 uninsured adults in Texas. We asked them, gosh, it was like 80 or 90 questions about their financial situations, their employment situations, and ultimately, how that affects their decisions regarding insurance. After that, we conducted over 70 focus groups with uninsured Texans. This was my favorite part of the project, and so I'm going to spend quite a bit of time talking about that. Because I enjoyed it the most. After that, we followed folks as they attempted to enroll in the ACA exchange. And then we are in our final phase of the project now. We're doing some actuarial analyses on potential solutions to the uninsured problem. So if you take away anything, we hope that you take away this slide. 30% of Texas's uninsured population of not quite 5 million people are eligible for a free plan on the ACA. 56% are eligible for existing programs. That's about 2.8 million people. There are, that 30% figure is about 1.5 million people. And then the other one I wanted to note is this MCS and CHIP kids, that 8% total between the two down there on the bottom, that's about 400,000 kids. Now we focus on this because While Texas 2036 supports Medicaid expansion, we know that in the current political paradigm at the legislature, that it's dead on arrival. So we want to focus on the eligible but unenrolled population. And one of our talking points is that Medicaid expansion won't actually solve our problem. It'll get us 15% of the way there. But if we solved Medicaid, if we expanded Medicaid and had a 100% take-up rate, we would still be in last place. There's about 750,000 people that are in the coverage gap that we think could benefit from Medicaid expansion. But we need about 1.5 million people to enroll in health insurance in order to get us to 49th place, which is where Georgia and I think it's Oklahoma are. They're sitting at about 11.7%, and we're about 16.6% uninsured, which is a decline from 2021 to 2022. Our uninsured rate declined from 18% to 16.6%. That's about 340,000 Texans that received coverage mostly on the private market. It is unclear in this slide, and that's my bad. This refined number over here includes undocumented people, which is like an educated guess on how many undocumented people are uninsured. And we have our methodology for making that estimate is in that longer report that I linked to.
Okay. Emily? Sorry,
yes.
I had a question in the chat. The 30% that you mentioned, it's 30% of what? Is it 30% of uninsured that are eligible for free AC? Okay.
Mm-hmm.
And that's also under the current enhanced subsidies that expire at the end of 2025, which we all need to be aware of that.
End of 2025, Ken?
Yes.
Yes, the expiration of the subsidies is a known unknown. This is the paradigm in which we live at the moment, so this is kind of what we're operating under. But certainly those subsidies have been a huge help. One of the myths about uninsured people is that they don't work. We found that over 70% of the uninsured work, and a really significant percent make between 200 and 400% of the federal poverty level. This is important because we know that the legislature wants to find solutions for the working poor. So dissuading people from thinking that uninsured people are universally unemployed, I think is really important when building the case at the Capitol. 40% of the uninsured have an employment-related reason as their primary reason for being uninsured. This kind of pervasive idea that that insurance is exclusively tied to employment. I think that there's some low-hanging fruit there in the kind of outreach space that could really help folks see beyond that. And another 19% believe that they don't qualify for insurance. Again, like the outreach component of this that we'll talk a little bit about, I think is going to be really important for solving that.
Where is the 19%, Emily? Sorry.
So it's just this cannot qualify for health insurance and do not qualify, that these two pieces of the pie. Mm-hmm. I don't think that this slide will come as a surprise to anybody. We have, sorry, there we go. Almost 40% of the uninsured constantly worry that they will not be able to get the health care they need because they cannot afford it. This is a really conservative estimate because these options were presented to our survey respondents in a 7-point Likert scale. So there's actually 69% of respondents worry to some extent. It's just this 38% constantly worry about it. If we think about how stress affects physical health, I think this finding is really profound. I'm going to move into some of our more qualitative findings from our focus groups. Like I mentioned, we conducted 70 of them. They were held both virtually and in person. I sat in on several of the virtual focus groups. From those focus groups, which, you know, we sat down with folks and talked to them for about an hour and a half. Just about their lives and their understanding towards insurance and why they don't have it. We kind of gathered 8 profiles of uninsured people. They're not mutually exclusive. Several people are different, or you know, multiple of these, but we found that these were really helpful in kind of simplifying the groups of our uninsured Texans. Indestructibles tend to be young and healthy. And really just not interested in insurance. It's just seen as an unnecessary financial outlay. There's also a really fun, interesting group that I have deemed the great pretenders. These are folks that swear up and down that they are healthy, but just a few questions digging into that kind of reveals that they certainly are not healthy. But because they are not actively having a heart attack, they consider themselves healthy. That was a really fascinating group. The scrappy value hunters are those that take really extreme steps to care for themselves and their families that have nothing to do with insurance or sometimes traditional healthcare at all. My favorite story from this group was a guy who learned that you can buy amoxicillin at a feed store. And so that is where he purchases his amoxicillin when he gets an infection. We had another guy who said that he had his girlfriend watch a few YouTube videos on how to reset a dislocated shoulder. And then she like popped it back into place for him. And that was how he cared for himself. The Simply Can't Afford It is a fairly self-explanatory group. And then we also have our Hard Knock Life group. These are folks who have been just really beaten down by circumstances that are completely out of their control. Trauma, death, injury. This archetype is really in survival mode. So something as administrative as insurance is just really not on their radar. These are our last 4 groups. Mothers and caregivers, we found that mothers certainly will sacrifice their own healthcare in order to afford a trip to the clinic for their kids. The undocumented group, and we did have several folks that talked to us pretty candidly about their documentation status. Really worried about getting on anybody's radar. One gentleman in particular who he was insured, but his wife was not a citizen. She was working through that process, and they had a toddler, and they were advised to not enroll the toddler in Medicaid because it would potentially jeopardize his wife's immigration application. And so they were taking their toddler back and forth to Mexico for his appointments and medications and things like that. The anxious avoiders don't go to the doctor because they don't want to find anything that's wrong with them. And this assumed care group is really interesting. It's a small group. These are folks that are really not interested in insurance unless it is free and, I mean, readily available on demand. And this, like I mentioned, this is a small group. This group was entirely composed of people who had children as teenagers. So my assumption is that this is a group who, like maybe was enrolled in Medicaid when they had kids. The kids were enrolled in Medicaid. They're just accustomed to health insurance being free. And so anything short of that is just not interesting to them. Employment cost and confusion. Those are the three big challenges we identified when it comes to enrolling in insurance. These are fortunately, a lot of them are solvable problems. I don't want to dwell on the mental health piece for too long, because this is the mental health is kind of out of our wheelhouse at 2036 at the moment. But I did want to bring it up because the challenges that our uninsured Texans are facing with mental health are really, really significant. And based on my attendance in the focus groups, the number one way they're treating these mental health problems is with marijuana. A lot of it. The folks that I spoke to were spending between $400 and $600 a month on marijuana. This is not for recreation. This is to treat PTSD, depression, anxiety. And we asked them, if insurance was $100 and you're spending $400 a month on marijuana, would you enroll in health insurance instead? And the answer was universally no. The marijuana solves the problem. The health insurance is one step in a major journey to solving a problem. We kept this bit about the social anxiety on here because our researchers were really shocked by the number of people that confirmed their attendance into the focus group and then just bailed. And we were, our attendees in these focus groups received a pretty solid, what's the word? Money for participating. And so they were really shocked that for an hour of their time that these folks just couldn't get to the group. Eligibility is difficult to ascertain for these folks, especially when they're enrolling without any additional help, maybe from groups like yours or other nonprofits that kind of assist in the eligibility and enrollment process. There are just kind of innumerable questions that surround eligibility that make this a drop-off point for folks that are trying to get insurance. Income is really tough for people to accurately guess when employment is not kind of steady throughout the year. We heard that a lot. We asked folks about their perception of the Affordable Care Act. We also called it Obamacare, since that was, that's common parlance. About a quarter of people don't know what the ACA is. We have a few quotes that I just wanted to share from some of our focus group respondents about their opinions on the Affordable Care Act. Word of mouth is really important to this group. And it was pretty common for us to hear, that when asked about their perception of the ACA, they had a friend that had enrolled and it was anything but affordable.
Is there
this guy here? Oh, sorry, go ahead.
Oh, just a quick question, sorry. What was affordable?
Can you say that again?
Sorry, I mean, typically under our insurance plans, if you actually look at our pay stub and how much is going per month, it is several $100s that go per person that, so is there a sense on what folks would consider as affordable?
I would say I'll go back and check our survey data to see if we asked something like that. I don't think we did, but from the focus groups that I sat in on, affordable would be like less than $50 a month. But that is like, that's just from what I heard. And you can see down here, 100 to 300 is not realistic. Yeah, I think that these quotes kind of give you a little bit of an idea of that. And then I was gonna say this guy in the middle is my amoxicillin guy. He was a great participant. And again, for some of these young healthy folks, health insurance is just not considered a necessity. As we are talking about affordability, I just wanted to bring up this kind of drop in cost that you'll see here in 2021 after the passage of SB 1296, which was a focused rate review bill. We don't have to get into kind of the nuts and bolts of that, but essentially there's a process where TDI analyzes the actuarial value of the gold, silver, and bronze plans, and makes sure that insurers are maximizing the effectiveness of some of those federal subsidies. So now you'll see it is not uncommon for bronze plans to be free and for gold plans to be cheaper than silver plans. And you can see a little bit more, just these are for families in Travis County. You can kind of get an idea of what folks are paying right now. As a result,
today's not the day to get into it, but if anybody really wants to know the history and the reasons why gold plans cost less than silver plans and stuff, it's a complicated story that goes back to the Trump administration. But if you want to know, I can tell you about it because I lived it. So
yeah, it's the silver. So I can maybe give like a really fast, simple overview. There are two kinds of subsidies in the ACA. The premium tax credits reduce premiums. The cost sharing reductions reduce deductibles out-of-pocket expenses. In 2017, the federal government decided that they were no longer going to reimburse insurers for those cost sharing reductions, but they're still on the hook for shelling those out. So what would a business do? Well, they're going to load that amount that they're on the hook for cost sharing reductions into their premiums. But the premium tax credits are tied to the benchmark silver plan. So what an insurer would do, and now what they are required to do in Texas, is load the amount they're on the hook for cost sharing into the silver premiums, which increase the amount of the premium tax credit, and just kind of messes with the subsidy levels so that now your gold plans are cheaper than your silver plans and your bronze plans are sometimes free. It is far more complicated than that, but that's about we could talk about silver living.
Only low income people that are eligible for the cost sharing reductions. You have to be below 250% of the federal poverty level. So it's not everybody. It was just an absolutely absurd political decision to do that rather than what I and several other rational people said. It should be spread across all of the plans, not just the silver plans, but you only get the cost sharing reduction if you buy a silver plan. So it just created this incredible market distortion, which makes no sense. But
there's
one of many windmills that I continue to tilt at with the actuaries. So
yeah. And I will just really quick, let me go back. There is another, because of the actuarial whirligigs of the subsidy, you'll notice that there are some instances where like a 60-year-old person is paying less than a younger person, which may contribute to that those young folks' perception of lower value for these particular plans. Enrollment in the ACA is not particularly intuitive. The user experience is poor on the federal exchange. There are several drop-off points as you are trying to get enrolled. Once you indicate your interest, our respondents told us that they felt bombarded by text calls, emails. They felt like they were getting scammed by brokers, and would essentially like not try to complete the enrollment process because of this bombardment. Here are just a couple quotes from our respondents about the really crazy number of contacts they received after indicating their interest in the ACA.
One more quick commentary on this is because there's so many people now that are eligible for a plan that costs them nothing out of their pocket. The subsidy covers the whole cost. You have rogues, unscrupulous brokers who are out there trying to sign up all kinds of people, including some homeless folks that I'm aware of working with healthcare for the homeless that were working very well with the Harris County Hospital District with their gold card program and stuff. But they were, even though they're not technically eligible for a subsidy, the broker signed them up, the broker gets a commission. And so there's clearly a need for some new regulations around broker practice in the ACA if the subsidies are going to continue to be this high. So, but it's a real problem.
Yeah, there's certainly some element of fraud happening there. I think I think I read one report that said that the number of folks enrolled, this may have been in Florida, the number of folks enrolled for a free plan was like more than the population of people making that like eligible income in the state. So yes, there's certainly opportunities there to reduce fraud. These are just a few of the drop-off points we found when we were shadowing people as they tried to enroll. This population's really protective of their social security number. They didn't like that they had to plug that in before they were able to get an idea of what they might be eligible for or might pay going forward. Yep, just a summary of some of our findings from the enrollment shadowing portion. And I'll just, I'll mention here, we think that there's a lot that can be done. And this is, preaching to the choir to get at the eligible but unenrolled. Express lane eligibility, improving the ex parte process, using navigators, improving that access. Like those are all things that we think will be I think widely appealing to advocates. And then there's some solutions that might be a little bit more controversial. The state-based exchange is certainly one of those. I will, before I go dive into another topic, I'll just pause here. Jordan and Iris, if I need to bail here, that's fine. I don't want to take up more time than I'm allotted. I know I tried to go as fast as possible, but it still takes some time.
No, it's fascinating to see what you'll have done in the last year since we last heard an update. And I know people have been asking some questions throughout, but do y'all have any questions?
I did want to hear from Ken about the silver. Why is the gold more expensive than silver? Less expensive than silver. I don't know if there's a quick explanation for that.
So people between 100% and 250% of the federal poverty level get, if they buy a silver plan, they get cost sharing reductions, meaning their deductibles and co-payments and co-insurance is at a higher level. That means that from an insurance company standpoint, those policies actually should cost more than the price that they're charging. Right. So if you have a policy, a silver policy with a $2,000 deductible, but because somebody with low income is buying it, then the cost of that policy to the insurance company actually goes up because the insured person is not paying as high a deductible or as high as a copayment. That's good for the insured people, and it made sense. Why the people who wrote the ACA said it only applies if you buy a silver policy makes no sense to me, but that was what the rule was. But initially, when the ACA first started, the insurance companies were then that difference between what that additional subsidy, if you will, that the people got for the cost sharing reductions was paid to the insurance companies the same way the premium tax credits were paid to the insurance companies, right? That was a government cost. But in 2017, when Trump went into office and the Republicans controlled the Senate, they tried to defund, get rid of the ACA, do anything they could to throw sand in the gears. And so one of the things that they said was the federal government was not going to pay the insurance companies back for those cost sharing reductions. So instead of that, the federal government said, you can just charge more because now those policies cost more, but you have to spread it across your whole book of business. Frankly, some of us that were in that business were argued very strenuously that, okay, if you're going to spread it across the business, you should do it across all of your ACA business, not just the silver plans. But other people said, no, spread it across the silver plans because the credits are based on the second lowest cost silver plan. That will actually make the silver plans more expensive. More people will be eligible for subsidies. This is a great idea. Well, in fact, what it's now done is created a situation where silver plans have to cost more than gold plans because so many of those people that buy a silver plan that has a cost sharing reduction. I know that's way complicated and it takes about 14 times going through that to actually finally it all sink in, but it's just the politics of the ACA have caused a number of these really significant market disruptions and distortions. I would also say the increased subsidies have also, right? The increased subsidies are great, but if the increased subsidies are only for a short period of time and then go away in 2025, you're going to have millions of people who are going to go like, what the heck? Suddenly my insurance that didn't cost me anything cost me hundreds of dollars a month. And so we'll see a significant drop in enrollment in the ACA in 2026 if the subsidies are not renewed.
And
we should have a 3-hour discussion about this for super nerds that want to talk about it. It's just awful. And just so you know, Emily, I hang out with Charles Miller all the time and talk about these things. So it's like,
yes, I know you and Charles are buds. And there is page 46 on that report that I linked to, our full uninsured report. We'll also basically took what Ken said and wrote it down. So there is some additional information on there, but yeah. Do you want me to go ahead and bail here, Iris?
No, I think if we can go into the housing, I do have a question though, because I thank you for that. I think that was really, really helpful to put into perspective, like who the uninsured are, and also that misconception that these are people that are not working. Mm-hmm. And I also appreciated the hitting on those policy levers that we could potentially, focus on this next session. My question though is, we understand ex parte and express lane eligibility are great options to pull as a policy lever here at the state level. Are there others potentially from the call or from the hearing there at the HHS hearing on the Senate side, there is some discussion of who are the population that's under the 100%, I think is what they were saying. I can't remember, but that maybe we could expand. Is there another population that we can focus on to include in Medicaid that are working and try to get those people covered or create some sort of option there? Have you guys thought, or have y'all talked about that?
I know that that's a discussion. I don't think we have talked about that on our team. I think that there are some, so like with, and I won't dive into the state-based exchange too much, but if, you know, whatever, that if that happened, we would have several, $200 to maybe $300 million a year that we could play with to improve insurance for a population. So maybe that is, you know, establishing some assistance for small business to get those folks insured who like aren't insured, you know, would be very expensive to get their employees insured. There's a lot of things we could do with that route, with the state-based exchange. Again, you know, we want, if it's going to be done, it needs to be done well. And we understand that, you know, there's the 2.4 million Texans enrolled on the ACA is, you know, nothing to shake a stick at. So that would be, there's some room there. I know, so to that extent, that's what we have talked about. Yeah.
And I was wondering, has that population been defined? Like, can we define it or through the data? And maybe just at least start putting some policy out there and having that discussion started.
You know, we have the crosstabs for income versus like characteristics. I can see if there's anything interesting in there.
Okay.
Send that over to y'all.
Yeah, I think that would be helpful, because the other thing I was thinking, I know there's certain GR specific funded programs, like I think it's primary health, that is fully GR funded. And if they're funding that through GR, is there a way to move it into a population that's covered under Medicaid? Was the other thing that I was wondering. I don't know if anybody else has heard of, is that something that's like a no-go at the state level?
I don't know. That might be beyond my knowledge of the intricacies of CMS. And those requirements.
That's again a long discussion, but yes, there's enough 100% GR funded programs to cover most of the costs of doing the Medicaid expansion in terms of what it would cost the state to do it. It may take a little bit of the LPPF dollars from the hospitals though to and so, but I you know, it's like, I think if you get the, you know, in Ken's fantasy world, if you took all of those GR funded programs for both mental health, as well as there's still some women's health programs, there's some programs for certain oncology stuff only, like I think uterine cancer or some, you know, if you took all of those kind of things and the mental health stuff for the uninsured, and maybe 25% of the 1115 waiver or something like that dollars that the hospitals are kicking in, you would cover the state share. It's not a financial decision from the state. It's a political decision that it's just like, we don't want to talk about it. We don't want to. Is there a chance to take some to say, well, let's at least cover women in childbearing ages? That would be a good start, because we did 12-month continuous eligibility after, but interconception care or care before they get pregnant would also help reduce maternal morbidity and stuff. There's several options. I still think the mental health thing that Emily mentioned is actually a very interesting one, because if you have a mental health condition, so therefore you can't work, or you can't work full time because you're self-medicating and stuff, why wouldn't you try to help those people get Medicaid so they can get a job, so they can get off of Medicaid. So that's one of the things that I had a really good conversation with some of the policy people from Senator Johnson's office. Now, of course, he's a Democrat, so it's like instantly non-starter. But how could you find something that might be bipartisan like that, that would be sort of in the realm of social determinants, but a worthy population? Because even his office knows that it's unlikely that that a full expansion would happen. But the more data we have, the better. And the Texas 2036 data is as good as we have in the state. So.
Great, yeah, great data.
And quite honestly, for those of us who've lived in the space of trying to get people insured, there's like no real surprises there. And I think the biggest surprise, and the thing for all of us to take away from this, is nobody wants to put their own health insurance, and very few people do. So thinking the uninsured people would suddenly be the ones to do it, right? Those of us who have employment-sponsored insurance, we don't think about how much is getting deducted from Medicare. It's free, right? People on Medicare think it's free because they don't know that Part B is being deducted from their Social Security check, right? People on Medicaid, it's free. So asking anybody to actually, go out there and spend $1,000 a month on the policies, it's, a very, very small percentage of the population that actually pays it. And so there's a philosophical barrier to overcome as well. So it's not surprising that people don't buy insurance, even if they're eligible for subsidies. But we can certainly do more to make sure that it's easier to enroll, fair to enroll, and make sure people are aware the subsidies are available to them. So, but Emily, we're not going to suddenly become Massachusetts overnight, and no matter there is no path to that. It's like, can we get to 49th? Let's go to 49th.
Yeah, we can't be Massachusetts, but maybe we could be Oklahoma. We'll just have to set our sights a little lower.
So true. Yeah. So we have 12 minutes, and I know you have the housing. Is that enough time, or can we do the housing another day? I don't know. What do you think?
I'll leave it up to y'all. I can do the 5-minute version, and just give everybody kind of a teaser for what we're working on.
Let's do that so we know what's to come, and we can come back, and then we can spend the rest of the time there are a couple of things like the hearings that are time sensitive that we might want to get to really quick before people jump off.
Yeah, great. I will do 5 minutes. So Texas 2036 cares deeply about housing affordability. Our cheap housing is one of our best competitive edges in the state. I like to say nobody moves here to go skiing. They come here because the jobs are plentiful and the houses are cheap. But that affordability has been declining. So Texas 2036 last session, and we'll continue to do so next session, has been advocating for reforms in how we use our land. Essentially making sure that we are allowing land to be used to its maximum value. And what this means is we need to build more of everything: more houses, more apartments, more townhomes, more duplexes, more cottage courts. And, as we're thinking about reforming land use, which will inevitably lead to some increased density, and essentially make our cities more beautiful, more walkable, more people-oriented. What I wanted to kind of posit to y'all is that there's an increasing body of research that shows that the form and shape of our cities, the physical built environment, actually has an effect on health. When we talk about non-medical drivers of health and housing as one of those, I think that we spend a lot of time talking about, the downstream effects of poverty, housing instability, being cost burdened by your rent or your mortgage. Those are problems that could be solved if we made more money. But the actual physical built environment cannot be solved by increasing income. But what can solve it, and what can take a good step forwards towards doing so, is allowing for greater housing density through some of these land use reforms. So last session, that took the form of a bill that would allow people to build accessory dwelling units on their property by right, reducing minimum lot sizes. That's basically municipalities say a house has to be built on 5,000 square feet of land. That's a lot of wasted land that we force families to buy to house themselves. What you another one that you may not know, and I'll go really quick through here. If you work in the like racial justice space, then you already know how zoning has affected neighborhoods of color. You may not know that there is a remnant of Jim Crow era zoning enabling act, model act, that is still in our local government code. And it's in it's section 211.006 of our local government code. And it affects how neighbors are able to basically slow, delay, and stop new housing development. I think that this is a really compelling link between the health of population health and our built environment. And so this is something that I'm kind of exploring as a potential link for next session. And I would love y'all's support kind of as we go forward. If you are curious about how land use affects neighborhood health, would love to talk to you about it a little more. And I think there's a really great coalition around kind of the pro-housing movement that's going to do a lot of good work next session. And we would love to have more explicit support from some of our health related organizations. So I will stop there and happy to talk to y'all offline. Yeah, there you go.
That's great. Can you share the coalition information yet, or?
I would not put us under any formal banner. It's a pretty broad group, and one of my big projects for the summer is putting together a housing policy blueprint, which I hope will be like essentially a menu of options for legislators to take into next session. And that is being done with broad consensus building from the coalition. So we have, the usual suspects, the builders and developers are in there. But we also, Texas Appleseed has been a great friend of ours. We've got a lot of academics. AARP comes to some of our meetings. Habitat for Humanity. So we're all across the board. And I think it's going to be a good session for housing.
Is there a way we can get involved? Is it by contacting you?
If this kind of sounds interesting to you and looking at land use reforms is not too out there for your organization, I have my email should be at the very end there. Shoot me an email. I could wax poetic about housing all day. So happy to talk further.
That's great. Thank you, Emily.
Yeah, of course.
Thank you, Emily. Are you all connected with Texas Housers bi-monthly call on the state housing?
I don't sit in on the monthly call, but Ben, I talked to Ben.
Okay, cool. Just like linking
those.
I mean, it's the different direction, but I think they also are interested in having some more health focused people, and definitely Health Equity Collective. We've had a lot of work and a work group and conversations around like that health and housing connection.
Yeah. And I think Ben does low income housing, and that's a really key component. What we're working on is like the low hanging fruit of land use reform that requires no dollars to do. So
yeah, maybe it can help propel some of their work. Like there's some sort of connection there. So
I also think Srila and I have been having some conversations around the health and housing work group that's on hiatus right now. I think it might merit making a specific case for those who are in the health and healthcare space, how they can connect. To me, I'm seeing those conversations even when we had the work group active. Folks don't really see what is the opportunity for action and connecting them, particularly when you get into the nuances of land use. It feels like, you know, like two different planets, and folks aren't clear how to like what's their lane, you know? So I think that could be helpful in building engagement for those in the healthcare space. I don't know if others in the healthcare space on this call have thoughts on that, but that's kind of what I've seen happening in the conversations when we've tried to connect health and housing. And it seems that actually the root things that we're looking at are the land use pieces most often. Very compelling work. Thank you, Emily.
Yes.
Yeah, please. Yeah.
Round of applause. Thank you. This was
Thanks.
really
Thanks so much for letting me talk for so long. But I appreciate y'all's attention, and everything today was fast and high level, but happy to dive down on details with anybody that is interested.
Yes, I just popped Emily's email in the chat and it's right there. I know we only have like 3 minutes, but let's just quickly pull up what we had on our kind of topics list, and then we can email that stuff out and then continue that the conversations that make sense to have as a conversation next month. So this application, Heidi, I know that might be something that's useful to either, does anyone know, like Latoya or Sydney or Alicia emailed me she can't come today. I'm not sure if anyone knows about that application if Texas is applying. That was something that we wanted to bring forward. I know that Shelby, y'all have a new resource out around maternal health, and we can talk about that next month. Wes, we wanted to hear about this session, so maybe we can come back to that next month too, around affordable care and takeaways from that networking session. And then on mental health, these upcoming hearings, if there's anything anyone needs, I mean, we've linked, but are there things that folks need to know about those upcoming hearings? Okay. Oh, awesome, Latoya.
I would just add for the July 31st hearing that it's been changed to invited testimony only for agency and advocacy orgs. So that's
no more public comment.
Of my last reading of the updated hearing notice, no. That may change though as they get closer to the date. But 5 pages worth of questions to committee staff with various questions for each of the agencies, and then also based on our work within the Harris County Reentry Work Group, directly related to juvenile justice work and mental health, I've kind of asked for some of our members to be considered as invited testimony, but we are still not sure what's happening yet, and which is fair.
Okay, cool. Anything else on that, Sydney or Latoya?
I just put in the chat, I think that you can do public written comments on the portal for both of those. I'm not 100% sure. I don't have the hearing notice pulled up, but I'm pretty sure that is an option at least. Or what I've done in the past during invited only hearings is just write out testimony and email it to the committee members, which isn't always, like what we want to do, but it is something I have done in the past. And so I think that's kind of what we would do for this one. We're still looking at formulating comments with our public policy committee, but I know just trying to get some comments into Rebecca for that invited testimony, like questions. But that's kind of what we're going for.
Cool. Well, y'all are rock stars doing it without power too.
Right. I wanted to clarify, Latoya, then HHSC is going to apply for the maternal health model. Did I understand that correctly?
I'm sorry. Are you asking if HHSC is applying?
Yeah, because I thought that that's what the notice of funding opportunity was for, or is this different?
I need to look at it. I think I think it's open. I don't think it's.
I think the one I sent, it could only be HHSC. So maybe we're
Are we talking about two different things?
Yeah.
Okay, maybe so.
And
Yes, I think I was confused on that too, because there was a notice of funding that came out that NBHP was looking at. But it must not be this one then.
Yeah, maybe so. Maybe it's a different one. Iris, good catch.
Yeah. There's actually quite a number of maternal health NOFOs that have come out recently, which I think is exciting. But this one, because it was a state government, I wanted to raise it up with this group just to know if there were any conversations that maybe we might be supporting in an application in this space, because it does look like it could be very complementary to the work that we are doing in our region.
I'll research some more and see if I can reach out to others, because I'm interested in that one too. I think it would be good for us to at least pull down some of those fundings. Ken, do you know any more on this one?
Rosie's on vacation, and I think she was looking at it.
Right.
It seemed like we had a brief conversation with Ryan Dr. Van Horst, whatever his name, the medical director at HHSC, whose name is escaping me right now. And it was like, don't count on it kind of response. So
okay.
Well, and I kind of wondered for the ARPA-H heroes, I know some of the state work and grants might serve as matching. So that was part of my question, is the ARPA-H heroes work. And I know HHSC provided a letter of support in that space as well.
I'm sorry that Dr. Sampson dropped off too, because she may know too, because I think that she was thinking about this too. So anyway.
Okay, well, we can follow up.
I'll put it in the email, and maybe Dr. Sampson would know something based on that. Last thing, Iris organized a little side conversation on FoodRx, like with Rosie and Lindsay and Carolina. And so maybe we can, they're not here today, but maybe we could circle back to that and kind of try to see where things are landing there next month as well. I know it's 5 after, so we've lost a lot of folks, so we can wrap it up, but thank you all so much. I hope everybody stays safe and can go somewhere cool for those who still are without power. Thank you all. Let Iris
Thank you.
I know if you need
Thank
anything.
Great work, everybody.
Bye.
Bye-bye.